So without further ado, we would like to introduce our first speaker. So Dr. Jeffrey Mosko, he's a gastroenterologist and an associate professor of medicine and a clinician in the Quality and Innovation program at St. Michael's Hospital and University of Toronto. Actually a guest lecturer at one of my classes, which was a surprise. He is a co-director of both the Advanced Endoscopy Fellowship and the international co-director of course of Therapeutic Endoscopy. His clinical trials expertise is both in luminal and pancreaticobiliary advanced endoscopy, and his research interests are in quality improvement and endoscopy. Please help me welcome him.
Okay. Hi, everyone. I usually start all my talks with a joke, but I was quite overwhelmed by the introduction and the amazing things that you guys have done. So there'll be no jokes, but I really am honored to be here, so thank you. Okay, how do I get started? There we go. So, I'm a gastroenterologist, so my job is a lot easier than Natalie's, a lot easier than you guys. I just have to look. And so my job is to put tiny cameras into places where maybe they shouldn't really go. So we're going to talk about that today. And the question is can endoscopy rewrite the story of gastric cancer? And I think the answer is, I hope so. And so you guys are not alone. People in the room, it's amazing to see patients, to see caregivers, to see advocates. It really is an interesting room. And a total gastrectomy, unfortunately, like I know as a gastroenterologist, is one of the most challenging journeys in medicine. And so really it's your experience that helps shape the things that I do. And my job is to find ways to both help people to avoid that surgery, to cure them before they need it, and then to support afterwards. And so what does endoscopy offer? We're going to talk about this today. It offers early detection, it offers ongoing care, and it really helps you then protect the other people that you love. So again, these are the things that we're going to talk about. So why does early detection matter? Well, it changes everything. When I can find an early gastric cancer, or I can find changes in someone's stomach that are en route to becoming an early gastric cancer, we can cure that before it becomes a problem. And the numbers are quite dramatic. So how does stomach cancer develop? Well, there are lots of people in the room and scientists that are much smarter than me. But what I need to know is that there are ways along the pathway from a simple bacterial infection of the stomach called Helicobacter pylori, which some of you may have heard of already, which creates inflammation in the stomach. The inflammation in the stomach then causes a change to the type of cells that line the stomach. And once those changes have happened, the cells can go from just normal stomach cells to precancerous cells, then to cancer cells. And so what endoscopy can do, where we put a camera through your mouth down into your stomach, is we can detect this bacterial infection so we can treat it. We can see the changes to the lining of the stomach. We can find the precancerous changes and remove them before they become cancer. And then we can take early cancers and I can cut them out using innovative techniques that spare people surgery. And this is what I'm really passionate about. And we can do that before any symptoms appear. So H. pylori, Teresa, I told you I wouldn't forget to talk about this. Who should be tested? Well, anyone with a family history of stomach cancer, if you've had ulcers or inflammation in your stomach, if you're born or your family was born in a high-risk region, East Asia, Latin America, or Eastern Europe, If you have long-term unexplained stomach problems, indigestion, bloating, things like that, or you've had an H. pylori infection in the past. And so how do we test for this? Well, one of the most common tests that I do is the endoscopy, again, and we're going to talk about that, where I go in and I take a little teeny tiny microscopic sample from the stomach to look to see if the bacteria is there. There's also a blood test which can test for it, although that blood test is a little bit less accurate and only shows that you've been exposed to it at some point in your life. And there's kind of a funny breath test where we give you something to drink and you sort of blow and we test your breath. And that's usually only for after you've had treatment. The treatment is a 14-day course of antibiotics. We pile on lots of antibiotics, one on top of the other. It's not such a pleasant 14 days, but it is highly effective to get rid of this. And the bottom line is, this is a relatively quick and treatable condition, and it can decrease your long-term risk of cancer by up to 55%. So what is this upper endoscopy? Who's in the room has had an endoscopy before? Oh, so you've all had the fun. Okay, well, it's fun. It's more fun for me, but I've had one. It was not fun. So usually the test takes about 15 minutes up to 30 minutes, depending on what we're doing. Although some of my procedures, I did one last week that took 7 hours. That was a special scenario, but a great outcome because we saved an operation. You're usually sedated, meaning you're mostly asleep or comfortable. In some situations where we're going to take longer than 30 minutes, we put people fully to sleep. You go home the same day for the most part, and it's very, very low risk. And we're able to see kind of the entire stomach, the stomach lining. Again, we can identify any suspicious areas, any polyps or growth in the stomach, any ulcers. We can take samples completely painless. And we can remove precancerous tissues really in that same procedure. So here's sort of maybe a cartoon of what it looks like. And here we pass the camera into the stomach and go all the way down through the mouth. You're lying down on your side. And we can look at the stomach and just beyond the stomach and look at the high risk areas. You have nothing to eat or drink from midnight the night before, so you come in a little bit hangry but once the procedure's over, you're able to eat or drink again. And we freeze the back of your throat before. Everyone's worried about choking on the camera, and it's a choking sensation, but we're actually not impeding any breathing, and we just go and look in the stomach. And our cameras are pretty amazing. They've gotten better and better over time. The optics are excellent, and we have a channel that we can put little things through that we can use to sample or take a biopsy or cut things out. And so this is this is a special upper endoscopy that we do in patients who also are at high risk of polyps in their duodenum. This is using a special camera that looks through the side. We do this in patients usually with genetic syndromes where we're looking both at the stomach and at the ampulla, which is the connection of the gallbladder, the liver, and the pancreas to the small bowel, and we're looking for polyps. And so this is what it looks like on the inside, and I'm using this video, of course, with permission. And we go through the bottom of the stomach into the small intestine where all your food gets digested and absorbed. So here we're into the small intestine there, and then we're looking for any polyps there. And we can see, we have a pretty good view with this camera of this connection to the pancreas. We're looking for polyps and we're looking to prevent cancers in that area too. And there it is, and it looks perfectly normal. Hooray. You can't hear the cheering when I find it normal because you're sleeping at the time. So what's the gastroenterologist's role in all of this? Well, again, it's before diagnosis for screening. We're going to talk about this. It's treating H. pylori, which you all are now experts in. It's identifying precancerous changes. And then it's starting the discussion about canceling on hereditary risk. And we often work closely with the genetics program at Mount Sinai to talk about that. At the diagnosis, when we find something bad, well, this is where I come in. Well, I have to look at the area and determine, is this just precancerous? Is this cancer? And how deep into the wall does it go? Do you need a surgeon to help you, or is it just me involved? I use lots of different cameras to look. I can do ultrasound from the inside of the stomach. So that's the same type of camera that goes in through the mouth, but it has a little ultrasound probe on the tip. So I can look through the wall of the stomach at the lining and tell how deep something is traveling into the GI tract. And then I can cut things out. And our ability to do that has changed. We've been cutting things out long before I started at St. Mike's in early 2015. But people have been cutting things out long before, but our techniques here in Canada have dramatically changed even since I started practice. And this is something that I do all the time. And we help guide surgical planning. So if I remove it and I realize that it wasn't cured by my procedure, then that gives our surgeons a really good idea of what the stage is. After treatment, I do surveillance. I look at the site that I worked on, has it healed up nicely, or are there any problems at the site? And then I look for other areas of concern in patients who are at high risk. And then we can manage some long-term complications too, both of our procedure and of patients who have had surgery, be it a partial gastrectomy or a total gastrectomy. And sometimes I'm involved in nutritional support as well. So things have changed over time, which is amazing and allows us to do our job better. And one of my jobs is to bring these technologies to patients and really bring them to Canada sometimes. And so we have high definition cameras now. So when I started, and I look back at pictures of when I started, I don't understand how I saw anything the way things are so high definition now. So we call that high definition white light. We have other different wavelengths of light, so we alter light to see different things in the lining of the stomach. We use different dyes to see better, and we have like really almost microscope level things on our cameras where we can get really, really detailed. So I can see the blood vessels going through, the blood cells going through the blood vessels sometimes really at a cellular level, and it's quite amazing. And so we've just upgraded all of our cameras, and so on your left is what we would see up until about a year ago, and now we added some new processors, and you can go from the left to a much more enhanced image. I don't know if you can see it that well with the light. It's a little bright, but it's much more enhanced. The color's enhanced, the texture's enhanced, so you can see a lot better. And then, we add different types of light and different post-processing imaging. So our computers are better, and so we can really, really go from this in the top left, which is kind of where we were at a year ago, to the bottom right to where we're at now. So to my eyes, maybe not to yours, but to my eyes, and I do this all day, every day, a dramatic improvement in our ability to see, detect, and characterize. And so that allows me to do something like this. This was a patient who'd had 4 endoscopies with random biopsies from her stomach showing cancer. So there's nothing scarier than your doctor saying, I found a cancer, but I don't know where it is. And if you don't know where it is, the only option was a total gastrectomy. And so this patient came to me absolutely desperate, saying, I need someone to find this cancer. And at the time, we were the only site in Canada that had new technology and these new scopes, and I worked hard to bring them to Canada. And I found the area of concern in the first 5 minutes. You can see it there in front of you. There's something that's just a little bit different, extremely subtle. And fortunately, I was able to find the area, mark the area, and then remove the area using a special technique called Endoscopic Submucosal Dissection, where I'm able to cut this out in one piece, and this was a curative resection. So no surgery, no chemo, no radiation. This patient went home after 1 day with the cancer cured. So this is something that we couldn't do just years ago and we're able to do now. So 5th endoscopy was the charm for this patient. And our new technology, the research is showing that it improves our visibility in gastric cancer. It improves our visibility in precancerous lesions, and so we're doing a lot better. We're also doing a better job at innovating in terms of being able to do things in a less invasive way. So after a gastrectomy, you're in hospital for, I assume, more than 1 night, but now, I know that's an understatement, but now we're able to remove these lesions, and this is an early gastric cancer as well, and I can suture from the inside as of about 1 year ago, and I'm able to send patients home on the same day. So you take a procedure that historically is a very morbid surgery. We can now remove the early ones in a minimally invasive way with endoscopy, and I can suture now these things closed at the same time and send people home from the endoscopy unit. So you go from a long stay in hospital to no stay in hospital. So again, we are pushing the limits of what we can do. Maybe the most exciting thing, just like you hear about in every realm and every industry, is AI. So what can AI do? Well, it's helping all endoscopists do the things that the very expert endoscopists can do. So it's helping people find suspicious areas. It's helping us tell if this area is really a concern. So is it a cancer or is it not? And it helps us tell us that we've seen the entirety of the stomach. So one problem that I have with some of the endoscopy that's happening across the province is that it's just very low quality. Well, now AI is going to tell the endoscopist that they're doing a good job. And so we're just scraping the surface of this in Canada. It's been a long process to get it approved by Health Canada and to bring it to market. And our equipment is just being set up to start, and we're going to have the first upper endoscopy proper AI system in the country. So stay tuned. So I'll update you on how that went maybe next year. If I'm ever invited back, I don't know. We'll see. But overseas, it's common. In Europe, they're using it, and so we're going to be the first in North America, actually. So we need to learn from the Asian experience. Toronto and Canada is a multicultural society, but we're not doing what we should be doing for our high-risk populations. So in Japan and Korea, they have a universal screening above the age of 40, and they detect early stage disease commonly, and the 5-year survival rate as a result is dramatically better. In Canada, I'm embarrassed to say that we have targeted screening to high-risk patients, but we're not doing it. We don't find these lesions early, and our 5-year survival rates are awful as a result. So patients are showing up late, they're showing up sick, and they need dramatic surgeries and chemo and treatment, and you guys know that better than I do. So hereditary risk is obviously something that we deal with all the time. So some of you in the room are at higher risk of gastric cancer than others, and you get treated differently. You get treated with lots of endoscopy and careful endoscopy, and we do that to help detect these lesions before you need surgery. What about after a gastrectomy? So nutritional support is paramount. You have multidisciplinary teams that are helping you with that. Sometimes there's bile reflux, where bile from the liver comes back up and has a much easier time coming back up into what's left of your stomach or your esophagus, and that can cause problems. And so we can look for that and help with that, and there are some medications to manage that. One of the things that I do is manage strictures or narrowing. So sometimes after you've had surgery, not when Natalie does it, but when you have surgery, things can narrow down at your anastomosis or the connection there. And so I can stretch that out. I can put stents across. And I just brought a new technology to the Canadian market called Cryotherapy. You've probably heard of that on the skin, but I now use cryotherapy to help stretch out surgical anastomoses. And we've done about, they've done about 17,000 cases in the US. It's only available there. And we're the first program in Canada to do that, and we've done about 20 cases now. So exciting things to come. And then we do surveillance in patients who have had partial gastrectomy. I still need to keep a close eye on the rest of the stomach. We need to continue to even people that have been cured, we need to look for new lesions in those that are high risk. Tell your family. It's one of the amazing things that My Gut Feeling does on the advocacy side is it provides education to families, help making sure that families at high risk are all getting screened. And sometimes, my focus after an endoscopy that's been normal is to talk to the chauffeur of the patient who came and say, well, have you been screened? When was your last endoscopy? Have you had a colonoscopy? And sometimes, they look at me funny and I'm like, well, you're next, right? And sometimes we find high-risk things in family members. And so, the guidelines are just guidelines. We have to tailor our approach to individual patient needs. And so talk to your family. If you're at risk, you need to be tested for H. pylori. Talk to your doctor about that and determine whether you need endoscopy or surveillance endoscopy. There are just too many gaps for early gastric cancer. There's no universal gastric cancer screening program, so we have a lot of work to do on that. The public awareness is just not where it should be compared to colorectal cancer and breast cancer. So I'm doing the bum run tomorrow, which is a run for colorectal cancer screening and awareness. And our team at St. Mike's is called the St. Mike's Sweet Cheeks. And I didn't make up the name, I wish I did. But there's lots of awareness around colorectal cancer. I'm a spokesperson for them as well. I think I can do both. I can do both, upper and lower. My job is upper and lower. So I can do both. And so there's lots of talk on colon cancer, not enough talk about what I call upper GI neoplasia, and gastric cancer is part of that. And there's really inconsistent access to the gold standard techniques. So I do these special procedures, but my procedures aren't funded by the government. So the hospital gets no reimbursement and I don't get paid for it. But I don't care because that's what's right for patients. But the problem is because of those barriers, there's only 10, 15 people across Canada that are doing these types of procedures, which means that there is inadequate access to patients for this surgery sparing technique. And that's something that I'm working on. How can we educate more people and how can we get the government to listen and fund these minimally invasive procedures? And there is some momentum. So I'm helping to train more endoscopists to span out across Canada. And the AI adoption, like across the board, is going to help us pick out these lesions and find them early and get them to where they need to go. Things are coming down the pipeline. Liquid biopsy, meaning a blood test that can maybe tell you you're at high risk, and there might be some researchers in the room that are doing work on that. There's swallowable capsules that we can now drive around, and I'm working with a startup with that, and so maybe my job is going to be obsolete in a few years when robot capsule can just swim around and tell you if you're at risk. And then the next generation of AI is going to, tell the endoscopist what to do. Say, ding, 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 here's the problem, biopsy here, and here's where to send it, hopefully to me. So we've sort of covered all this about things to ask your doctor, and so I won't belabor this point. But I will tell you about one of the new initiatives that I'm doing because of this inadequate screening and screening programs. I've teamed up with 2 other gastroenterologists to create a new ambulatory endoscopy center in the downtown, which is shockingly an underserviced area in Ontario. And so we have government funding to do now up to 22,000 procedures. And a lot of these will be screening, and we're going to develop an upper GI neoplasia program there for screening high-risk patients at risk of esophageal cancer and gastric cancer. And we're teaming with St. Joe's and St. Mike's to make this happen. So stay tuned for that. We're hoping to open in the summer. Construction's underway. So from the bottom of my heart, thank you so much for having me. Thank you for everything that you do. Endoscopists play a role in moving the needle on gastric cancer, and I think slowly endoscopy is rewriting the story in gastric cancer. So the future is bright. So, we're trying. Thank you so much.
Thank you so much, Jeff. So I've got, I guess, a bit of a joke because actually Jeff is my gastroenterologist, and when I asked him, he's been my gastroenterologist for a few years, and he's actually my family's gastroenterologist, so there you go, we're following the rules because we are at high risk. And I remember I said to him just recently, I said, I'm so thrilled to be able to see you outside of your clinic finally. So thank you so much. I'm so happy about all the work that's being done at St. Mike's. I know that their GI department is one of the best in the country. And thank you for that. That was a fantastic presentation.